Good afternoon to everybody, but also good morning and good evening to some of us. It is our pleasure to welcome you to the 5th ITM alumni webinar focusing on COVID-19 in Kenya, and more particularly on the interventions, challenges, lessons learned, and way forward. In the ITM alumni webinars on COVID-19, ITM alumni present their impressions on the current situation of the outbreak in their country and highlight how they are engaged in this global fight against the pandemic. The main aim of this series of webinars is to share experiences, expertise, and good practices within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. Our today's moderator is Professor Dr. Bruno Marchal. Bruno Marchal joined the Department of Public Health at ITM in 2000, after working 6 years in Kenya at district level. Bruno is professor and head of the Health Systems Unit and the program director of the postgraduate certificate course in tropical medicine and international health. He mainly works on strategic management of healthcare organizations and stewardship, urban health, and research methodologies for complex issues in health. Since 2013, Bruno is a visiting researcher at the School of Public Health at the University of Western Cape, Cape Town, South Africa. Bruno, please.
Thank you, Charlotte. It is indeed my great pleasure to moderate this seminar, but also to introduce Dr. Anne Muendi Musuva. So she will present the response of Kenya to the COVID-19 pandemic. Now, Kenya reported slightly over 2,000 cases and just over 70 deaths, which is low from a global perspective, but it's relatively high if you compare it to the neighboring countries, Tanzania, Uganda, and Ethiopia. Now, Anne is quite well placed, as I said. She has more than 10 years of experience in designing and implementing disease prevention and treatment programs, but also quality assurance interventions and managing district health systems. She's currently working for Population Services Kenya. Anne complemented her master's in public health, or completed rather her master's in public health with the orientation disease control in 2012 at ITM. She was an emerging voice in 2014, and she is a representative of many of you, of the alumni, in the General Council of ITM. At this moment, Anne is involved in managing the Corona outbreak in Kenya as a member of the COVID-19 National Task Force, and she represents the Kenya Healthcare Federation in that task force. She's very well placed to discuss Kenya's response. And Anne, I would like you to take the floor, please.
Thank you very much, Bruno. Yeah. So it's an absolute pleasure to have this opportunity to share some of our experiences in Kenya on COVID-19, some of the interventions and strategies that we have put into place, and also some of the challenges that we are facing and what we see as the way forward. So this will be the outline of my presentation. So just a little bit about Kenya to paint some context. Kenya is a pretty large country, the population of 47 million people. We have a devolved governance structure, so we have a national government, but we also have 47 county governments that have quite a bit of autonomy, and health is also a devolved function. So the county governments are actually the ones in charge of health. Kenya relies heavily on agriculture and tourism, and as you know, right now with the COVID, tourism is really affected. 80% of our workforce work in the informal sector, and this is particularly important when we're talking about issues to do with working from home, where the informal sector actually has to show up in order to eat. They have to show up at work in order to eat. So that is a big problem. Looking at a snapshot of our health system, in Kenya right now, universal health coverage is one of the government's big 4 development agendas, others being agriculture and manufacturing. And so the government is actually putting a lot of emphasis right now on universal health coverage. However, when we look at the government expenditure on healthcare, this has flatlined at about 6%, between 5 to 7% for the past 10 years or so. This is really a far cry from the target of 15% based on the Abuja Declaration. Our per capita expenditure on healthcare is just $78, and our healthcare workforce is quite inadequate, where we have 13.8 healthcare workers per 10,000 of the population. Now it's estimated for us to reach a universal health coverage, the WHO talks about 250 healthcare workers. So I also want to paint some context on what is happening in the country right now, since the first COVID case was diagnosed in Kenya on 30th March. So COVID is not the only thing that has been on the mind of Kenyans. We've had a locust invasion that began somewhere late last year in the northern and eastern and central parts of the country. So we're also dealing with that. We are just right now recovering from heavy flooding in over 10 counties in Kenya, where we had over 116,000 people who are displaced and 237 people who actually died from the flooding. So there are a lot of sort of disaster-related issues that we are currently dealing with right now, in addition to a cholera outbreak because of this flooding in 2 counties in Kenya. So this is the context in the country right now. Now, looking at the COVID-19 epidemiology, the first case in Kenya was an imported case on 13th March. And since then, we've really seen an increase in the cases in Kenya. Right now, the cumulative cases stand at 2,093. Initially, they were all imported, but the bulk now are locally transmitted. 86% of the cases now are due to local transmission. We've had a 71 mortality so far with a case fatality rate of 3.4%. And just in context, comparing this to Belgium right now, where the case fatality rate is 16%, I believe the highest in the world. And we have our neighboring Uganda, countries such as Uganda, where the case fatality rate is 0. Uganda hasn't had any fatality so far from COVID. COVID started in, if you look at the map on the right, we had our first case diagnosed in Kenya, in Nairobi. Nairobi is the capital city of Kenya, and of course, there's a lot of movement and traffic, with the airport and so on. So, and at the very bottom, on the bottom right hand, we have Mombasa, which is also another big urban town. So this is really where we have the bulk of the cases in Kenya. Actually, over 80% of our COVID cases are in Nairobi and Mombasa. The cases were first started in clusters in sort of the uptown areas in Nairobi, largely because of the people who live in those areas are those who are likely to travel out of the country. But this has very quickly spread to the slums and other informal settlements in Kenya. And that is not the mainstay of the virus. Most of the new cases are actually being diagnosed in the informal settlements, and this is a big concern to the country. This is a trend of the COVID-19 cases in Kenya. You may not be able to see everything very clearly, but probably what I want to highlight is that since the very first case on 13th March, we've had a steady increase in the number of cases right now. I'd like to point your attention to a date somewhere there in the middle, on 30th April, where we actually started mass testing and really stepped up our testing capacity. And you can see that the number of diagnoses, so the number of cases that we are seeing every day increased significantly. So this really points to the fact that despite our low numbers, this is largely because of low testing. We are now testing about 3,000, we are now conducting about 3,000 tests per day, up from less than 1,000 about a month ago. And then we've really seen our cases go up. So the more we test, the more cases we're able to get. Just delving into the epidemiology and looking at the presentation of our COVID cases in Kenya, 85% of the cases are symptomatic. And this ties largely with what we are seeing in many other parts of the world. When we also look at the presenting symptoms, half of our patients present with cough, and almost half again present with fever as well. So these are the 2 largest sort of presenting symptoms amongst our patients. And this is also quite consistent with what we are seeing in other parts of the world. When we look at our age and sex distribution of our confirmed cases, the bulk of the cases are actually between 20 to 39 years of age. That's where we are seeing most of the cases. And this is a bit different from what we see, for example, in Belgium, in Europe, and in the US, where the bulk of the cases are above 40 years, 50 years, 60 years, and so on. 65% of the cases are also male. So the majority of the cases we are seeing are actually male. And this is not also very consistent with what we are seeing in other parts of the world, where the ratios are pretty similar, or we only have slightly more male cases than female cases. But in Kenya, 2/3 of the cases are actually male cases. Now, when we look at the mortality, as we see in other parts of the world, the mortality increases with age, and particularly so in men. So if you look at the graph here, you can see that about half of the deaths are actually amongst Kenyans who are over 60 years old. Men are actually much more at risk. We've seen 77% of the deaths are actually amongst men compared to women. And specifically men over 60 years, though they only account for 7% of the cases, they constitute 41% of the mortalities with a case fatality rate of 29%. So this is a very high case fatality rate amongst men who are over 60 years. So that's just a snapshot of the epidemiology. I'd like to very quickly go through the government response, what sort of the strategies the government has put into place. So there are 4 main strategies that the government has put into place. One around public health, restrictions in movement. There are various governance and economic strategies, and also strategies around social distancing. So I'll just talk a little bit about each of these. So this is the current coordination structure that we have. On 28th February, this was actually about 2 weeks before the first case was diagnosed in Kenya. An executive order by the president established the National Emergency Response Center, the NAC. This is a multi-sectoral ministerial platform shared by the Minister of Health, and other ministers are also part of this platform. So we have the Minister of Education, Treasury, Security, Interior, and also we have a representative from the Council of Governors representing the county governments. And the main role of this National Emergency Response Center is actually to coordinate the entire preparedness and response, not only from a health perspective, but also looking at all the other issues that, sort of go beyond health. If you're talking about security, contact tracing, where you need the Ministry of Interior is actually the one responsible for that. Now, reporting to the National Emergency Response Center, we have the COVID-19 Technical Task Force. So this is a task force that is focused really just on the health sector. So all the players are in the health sector, but this also goes beyond the Ministry of Health. So we have the Ministry of Health, the permanent secretary chairs this task force. We have the Kenya Medical Research Institute. We have various universities that also involved in research. We have the Kenya Medical Association, Kenya Healthcare Federation, and other such agencies. And their role is really to coordinate the public health response. And then we sort of have the nerve center of this coordination, which is the Emergency Operations Center, the EOC, Incident Management Team. This is a team comprised by staff from the Ministry of Health and the Kenya Medical Research Institute. And they're really involved in surveillance, day-to-day management, and also they're involved in generating or developing the daily situation reports on COVID. So this is the coordination structure, and right now it's working pretty well. Obviously, at the National Emergency and Response Center, they also coordinate with the media and with the security as well. So the approach is really a whole of government approach. It's not just focused on the health sector. And we've also seen very strong public-private partnerships with universities, for example, with the PPE manufacturers to step up production of PPEs, with different telecommunication companies that the government has also engaged to support in the response, with banks as well that have been compelled to give exemptions to people who are defaulting on loans because they have lost their jobs. So looking at some of the strategies that the government has put into place around social distancing. So the government adopted a phased approach. So we saw sort of incremental strategies coming into place one by one. On 15th March, we first had a closure of the learning institutions. So all schools were actually closed, and learners were encouraged to learn from home. So we have virtual learning going on in some centers, but obviously that is very inequitable. In the rural areas, most of the children don't have access to virtual learning platforms. The government at the same time also strongly recommended remote working from home. This is probably possible for people such as you and I, but bear in mind that 80% of Kenya's workforce works in the informal sector. So obviously remote working doesn't work for them. So these are people, for example, who work in construction sites, in homes such as domestic workers, and other parts of the informal sector. A week after these measures were put into place, the government also made it mandatory that for public transport operators, they would only operate at 60% capacity. So you'd only be able to carry 60% of the passengers you'd have carried before. Obviously, this has led to an increase in fares. And the main thing the government was looking at here is really social distancing and ensuring that there's a distance of at least 1 meter between the people who are seated in the vehicle. There was also a ban on public events, such as weddings, such as funerals, with only 15 people, with only a maximum of 15 people recommended to be able to attend any public event. Now, this might not be a very big deal in Europe, but the average wedding or funeral in Kenya has about 500 people. People travel from all over Kenya to attend a wedding or a funeral. So this is really a big, it's a big social issue. I personally lost my aunt about 3 weeks ago and I couldn't attend her funeral because the family had to choose who would come for the funeral. We also had the religious institutions closed. And in Kenya, more than 80% of the population either go to church or are Muslims or are Christians and go to religious institutions once a week. So this was also a big social challenge. The other thing that the government also did at the same time was to close public facilities. They also closed restaurants and bars. Restaurants were actually only allowed to provide takeaway services. And so obviously this has had a big effect on the economy, given that all these facilities are actually closed and cannot provide services. When we look at the movement restrictions that the government put into place, on 25th March, the government announced a suspension of all commercial and international flights. 2 days later, the government also announced a nationwide curfew of between 7 p.m. To 5 a.m. So you cannot be found walking around after 7 p.m. and the police are actually at hand to enforce this measure. The main thinking here was, again, banning movement and also social distancing because people cluster in bars, in restaurants and hotels in the evenings. A week after that, we then had a lockdown of certain cities that had huge numbers of COVID cases, such as Nairobi, the capital of Kenya. We also had Mombasa and Wajir and a few other cities as well. Now, this came just a few days before the Easter holidays. Kenyans often travel to the rural areas where actually the bulk of the elderly population live. And so the government was trying to stop that movement from the urban areas to the rural areas just during the Easter period. On 16th May, so last month, we also had the closure of our borders with Tanzania and Somalia. And this was largely informed by the different strategies that Tanzania and Somalia were taking to address COVID and the increased numbers that we saw of COVID cases from people coming in through the Tanzania and the Somalia borders. Obviously, this has led to tensions between the two countries, which we are trying to address. Other measures, economic measures that the government has put into place. The government announced about 2 weeks ago an economic stimulus package, which is meant to cushion both individuals and businesses. So the government has released funds that are going directly to recruit the youth that will be engaged in certain national activities. There also funds, sort of like a cash transfer, that is going to be given to the elderly population and other vulnerable populations to cushion them during this season when many people have actually lost their jobs. The other measure that the government put into place was recommending cashless transactions. And they actually partnered with mobile money operators such as Safaricom, which is a big telecommunications company, in order that all cash transactions under $10 are actually free. So I personally have not handled any cash for the past 3 months, and that is the case for very many Kenyans. And so this is again just meant to reduce any exposure to COVID. And so this is something interesting that we'll watch to see after COVID, whether the cashless transactions will be on the increase or whether people will actually revert back to using cash, as was the case before. Government has also partnered with the various local industries in the manufacture of PPEs, sanitizers, test kits, which are being manufactured by the Kenya Medical Research, Kenya Medical Research Institute, although the test kits are not in use yet. The government has also announced a number of tax relief measures targeting both small businesses, but also individuals, which were very welcome, of course. In terms of the public health strategies that the government put into place, there are many guidelines that have been developed to help healthcare workers and other industries manage COVID. The current case management guidelines right now are focusing on supportive care of patients. There's a lot of capacity building that has taken place for healthcare workers. It started off with the face-to-face classes, but this has actually now moved to virtual sessions. We've had 3,000 healthcare workers recruited on short contracts in order to be able to support the COVID response. And the government has also put in place mechanisms to support healthcare workers in terms of mental health. In terms of the lab and testing capacity, we started out with 2 labs in Nairobi that were able to carry out COVID tests, but this has quickly been expanded to 20 labs in 10 counties right now. And to date, we've carried out 82,000 tests with a positivity of about 2.5%. And the strategy right now is actually expanded targeting testing. So most counties have actually isolated where the hotspots are, where we sort of have clusters of cases. And in those areas, the government is carrying out free mass testing. But there's also targeted testing for healthcare workers, especially those who are on the front line of the response, truck drivers. So there's testing happening at the borders where a lot of truck drivers are coming in, because we've seen very high cases amongst the truck drivers, then amongst also those in the hotel industry. So one of the requirements for the restaurants to be able to open up is that all the staff in a restaurant must be able to, must have had a COVID test done to be, and declared negative for them to be able to work in the hotels. Yeah, I think I'd talked about that. So in terms of facility preparedness, in all the counties, they've actually identified isolation centers, which are sort of separate from the hospitals, with a bed capacity of 3,400 beds. We've also mapped out the ventilators and the ICU beds that are available. And obviously these are inadequate, and plans are being made by the government in order to increase our ventilator and ICU capacity. In terms of quarantine, the government started off with a strategy of self-quarantine. So for example, if you are coming from out of the country, from abroad, from countries that initially had detected COVID cases, people would be encouraged to self-isolate at home. But this very quickly moved to mandatory quarantine for all arriving travelers, and also for the close contacts of cases. So quarantine centers have actually been identified. We have 467 quarantine centers that have been identified in all 47 counties, with a bed capacity of over 150,000. And so these quarantine centers are schools. We have hotels, both high-end and low-end hotels, and other non-health institutions are actually being used for quarantine. So if you're coming from out of the country, as was happening before, you could actually choose where to go for quarantine based on your budget, because this is actually at your cost. And this has been a big problem, because some people would say that they don't have the funds to be able to pay for the quarantine facilities. And in those cases, the government is then able to provide a waiver. There have been many communication campaigns going on targeting the general public with health information and messages. The messages really are focused on risk perception, hand washing, on respiratory hygiene, and also on the use of masks. Masks are now mandatory in Kenya since about a month or so ago. It's mandatory to wear a mask in Kenya if you're out in the public. Disinfection of public places is also going on. So these have actually been mapped, and disinfection is ongoing on a routine basis. So this is just a snapshot of some of the guidelines and the protocols that have been developed by the government. So you can see some of them, for example, on how to continue providing community health services in the context of COVID, how workplaces can prepare themselves, and also quarantine protocols, protocols for the management of restaurants. So there are very many guidelines that the government has been busy preparing, and those have been useful. So looking at what has worked well, in terms of preparedness, way before our first case in Kenya was diagnosed on 13th March, in January, the government already had a COVID-19 contingency plan that had been developed by the health sector. The National Emergency Response Center was also established on 28th February, and this again was way before we had our first case in March. And so there are quite a bit of preparedness efforts going on. We've developed guidelines and protocols in anticipation of the pandemic. There's also been a very quick response. So for example, our borders were closed very early, just immediately the first case was actually detected, the borders were closed. We've had screening systems that have been very quickly deployed at the points of entry. So at the airports, but also at the borders, the neighboring borders with the other countries where we have very many trucks coming in. There's also been accelerated capacity building. The government has partnered with other institutions such as AMREF to support in coming up with curriculum, virtual curriculum for training healthcare workers. So very many healthcare workers have been trained very, very quickly. Yeah, I think I'd mentioned that mobile labs have also been deployed at the border points to test the truck drivers. The other thing that has worked very well is the multi-sectoral coordination. So this really hasn't just been a health sector response. And related to that also is the public-private partnerships. Some of the ones I can just quickly point out are like partnerships with the telecommunications industry, where, like the toll-free line the government has right now. So that is being used for the COVID response for the general public, is actually run by Safaricom, our biggest telecom provider, in collaboration with the government. The government also impressed upon the telecom provider to reduce their tariffs and actually eliminate them completely for transactions below $10. Government has also really worked with the banks in order to, put in place measures for people who are defaulting on loans. The labs that we have right now, the 20 labs that are actually being used for testing COVID are both public and private labs. So there's been a lot of collaboration with the private sector. That said, of course, there are some challenges that we have faced. In terms of the movement restriction, I think the biggest challenge has been, the economic issues. 80% of our workforce is in the informal sector. And right now, this is actually when the tourism boom with with it being summer in the US and in Europe. This is when we usually have our biggest tourism boom. Yet, there's actually no tourism activity going on right now. So the economic repercussions have been huge. And there are very many questions as to whether the gains that we have with the managing all these prevention measures that we put into place, whether those, whether the challenges or the economic repercussions actually outweigh any gains we've had. Because with all these people losing their jobs and not being able to fend for their families, would you rather die of starvation or of COVID? These are all the questions that are there right now. There's a lot of pressure on the government right now to reopen the economy. We've also seen a skyrocketing of food prices, largely because of the delayed supply chain with all these, with the lockdown of certain cities. So the transportation of goods and services has really been a challenge. We've seen unrest and protests in certain parts of the city due to the lockdown. We've also had huge queues at various borders, such as our border with Tanzania, the Namanga border. And this is because of all the truck drivers, either have to be tested or have to prove that they have just been tested within the past 48 hours before they can enter the country. So we've had queues of trucks going up for about 50 kilometers, also leading to huge economic repercussions. We also have a wide porous border. So there have been cases of people actually being able to get in through these porous borders, through areas where the police are actually not manning. In terms of social distancing, when you think about the slums in Kenya, the informal settlements, it's almost impossible to actually, implement some of these measures. If you ask a family of 5 people living in a 2 by 2 meter room to social distance, that really is impossible. The slums are really crowded without access to running water. So when you're also talking about hand washing, this is really, it's actually close to impossible. We've obviously had cases of people escaping from quarantine centers, also because of the cost of the quarantine, and these are also possibly cases who could be positive. In terms of the public health response, we've really seen a decline of essential health services. Services are actually down 40 to 60% in most health facilities. Maternal health services, for example, immunization services, we've seen a big decline. And so there's a big concern as what the outcome or the impact of that could actually be. In the private sector in particular, the decline of those services has also had a big economic impact, where most of them actually have, from the funds that they get, that is actually what they use to pay their healthcare workers. So while we need our healthcare workers the most now, some of the private facilities have actually let go of some of their healthcare workers, and some have actually been put on half pay for these months, just because the health facilities actually, their income has really gone down. We've had challenges accessing test kits and PPEs, but this is a situation that is really not specific to Kenya. When we look at other social challenges that we face, there's a lot of stigma for those who, were in isolation centers and are now being released back to the community not really wanting to interact with them. We've seen an increase in domestic and gender-based violence, mental health issues with people being confined in small places. So these pictures just show you, in pictorial form, some of the challenges that I'm talking about. So this is a slum in Kibera. Kibera is one of the biggest, it's the biggest slum in Kenya, actually. So when you look at this informal settlement with no access to water, and it's so crowded, and we're asking people to social distance, to wash their hands and stay at home, it's almost impossible to do that. This picture just shows some of the long queues at the borders with drivers awaiting testing. Despite all the challenges we've had, there are some best practices. Kenya is actually a very entrepreneurial country, and some industries actually quickly saw an opportunity in this COVID crisis. So we've seen some industries quickly start producing masks. So this, for example, is Kitui Textile Industries. This is actually a government factory in a rural part of Eastern Kenya. So for example, most of the government agencies are procuring their masks from these Kitui Textile Industries. We've also had innovations by local universities, a university called Jomo Kenyatta University, where the students have developed prototypes of ventilators. These are the first local ventilators to be produced in Kenya, and these are actually under testing right now. The Kenya Medical Research Institute is also in the process right now of developing test kits that are going to be tested, and test kits, which they haven't done this before. So I think there have been some good practices that we've seen that can be emulated in other parts of the country. The other thing that we have seen that has been a good practice is the development of a real-time surveillance and a self-screening tool by the Moi Teaching and Referral Hospital. So this self-screening tool is actually on a USSD platform. And so someone at home can just self-screen themselves, take themselves through a number of questions, and depending on the responses, this information is actually real-time sent to the county, who can then use this information for targeted mass testing. But respondents or the public is also linked to the county hotlines for follow-up in case of screening, in case of a positive screen for COVID, for example. So these are some of the innovations that we've had in Kenya. Some of the lessons that we've learned are that community engagement is critical in preparedness and response. it's very important to test the acceptability and feasibility of some of the solutions before we roll them down at a community level. The strong multi-sectoral collaboration, I think, has also been something good and worth to be emulated. And also, obviously, continuous risk communication to the public, because we've seen that over time, there's sort of a fatigue that is creeping in amongst the public and also amongst the healthcare workers. So continuous risk communication is critical. So this is my last slide. So in terms of the way forward, there are discussions going on right now about reopening the economy. So the hotels were reopened about 3 weeks. The restaurants were reopened about 3 weeks ago, but with very strict measures for mitigating any adverse outcomes. So, you know, for example, the tables must be 2 meters apart. All the staff must be tested for COVID, and also very strict disinfection measures. But there are also discussions about whether to reopen the schools, when to reopen them, how to reopen them, and how to reopen the rest of the economy, because there's a lot of pressure right now on government, as I talked about earlier. We have a huge infrastructure for testing. We have 300 GeneXpert machines in Kenya right now. And we hope that, you know, this is an infrastructure that we can actually use to sort of scale up testing. So we're waiting for the cartridges, which we haven't received right now, because there's a current ban on exportation of the cartridges from the US. Then we are continuing to prepare the health system in terms of the surge capacity. Projections right now are, with the current mitigation measures, the peak of the pandemic will likely be around early next year, so in February 2021. So Kenya will likely see an increase in the number of cases, even as we continue testing. The more we test, the more cases we'll be getting. And so we really need to continue preparing our health system to be able to manage the cases. So right now, all cases, whether they are critically ill or not, are actually being kept in isolation at health facilities. So there are discussions right now about having home-based care, especially for symptomatic cases. The concerns obviously around the household outbreaks and increased community transmission, but also exploring the establishment of community quarantine centers. So centers that the community themselves have come up with. Kenya is going to be part of the WHO-led solidarity trial. So we're also looking forward to being part of that and seeing what results come out of that. In terms of some of the economic measures that the government has put into place, some of the challenges we've seen is that they are not reaching all vulnerable populations. And so the government is being strongly encouraged to really make sure that all the support that they put into place, the cash transfers, reach all who are vulnerable in order to sort of mitigate the effects of COVID. So thank you very much. That was my presentation. I'm looking forward to questions and engaging further. Over to you, Bruno.
Yeah, thank you very much, Muendi. This was a very clear presentation, well structured, and I think I would like to use the structure of your presentation to deal with the questions which have been posted. So we have a number of questions, in fact, covering all of the aspects of the seminar. I would like to ask you to still post additional questions. We will try to address all of them, but that may not be possible. So let's start perhaps with the question of Mishra, who said, okay, and this is a question about the availability and quality of data. Is it possible that deaths might be occurring among possible COVID cases who may not have been tested? And have all deaths that occurred in Kenya been tested for Corona? So the whole question on attributing deaths to Corona and vice versa.
So I would say that there's certainly a likelihood of that happening. But you know, surveillance is also showing that we are not having like an increased deaths in health facilities, or even at community level, unexplained increased deaths. We haven't seen that beyond the COVID deaths that are being reported by the government right now. But obviously, because not everyone is being tested because of the limited testing capacity that we have right now, it's certainly possible that there are some deaths that haven't been captured by a current surveillance system. So that is certainly possible. But I would think it's to a very small extent.
Yeah, all right. Then there's a question about testing capacity and in how far besides the health facilities, also veterinary health facilities have been involved in testing.
Sorry, I didn't get that. Yeah.
So the question is about the degree to which other sectors, and especially veterinary health sectors, have been used to diagnose in this epidemic.
Okay. So most of the testing right now is focused on sort of health institutions, so hospitals, but also research institutes. We have one, the Institute of Primate Research, that is also being used as a testing center, but the bulk of the testing centers are not vet centers. I think it's only one. So right now we have 20 testing labs all over the country, but most are actually focused in hospitals or in the Kenya Medical Research Institute sites.
Could you perhaps comment on the adequacy of that offer of testing? Is the testing capacity at this stage sufficient, you think?
So we currently do not have adequate test kits right now. So we are still not able, for example, to test everyone that would want to test, including healthcare workers. So in some counties, for example, healthcare workers on the front line were only tested once. We are not able to have a repeat testing, whether it's on a weekly basis or on every 2 weekly basis. In some counties, for example, some restaurants haven't been able to reopen because the hoteliers or the staff working in the restaurants haven't been tested, just because we still don't have adequate testing capacity. So we are really looking forward to expanding this testing capacity with the gene expert machines, but this is not in place yet. Yeah.
Okay. Then there's a question about, again, data. And the question is about any social or socio-economic inequalities in the mortality data, especially for Kenyans who did not travel. So the kind of community infected cases in Kenya.
About any socioeconomic disparities or inequities in the data.
Yeah.
I wouldn't say that has been teased out yet very well beyond the age and sex distribution that I showed. But what we are seeing right now is that the bulk of the cases are actually in the slums. While before the clusters that we had were more in the affluent areas because of those are the people who travel. But so more and more cases are actually being found in the slums, and hence the mortalities as well. But this is not data that we've teased out very well. Yeah. So I think that's something to look at further.
Yeah. We may discuss that later when we look at how the decision-making processes take into account inequalities in deciding on measures. Perhaps the last question on the monitoring and surveillance capacity is about, is there a live dashboard for COVID-19? Something which has been done in other countries, Nigeria and South Africa. It's a question of Maxwell.
Yes. So we have a live dashboard at the technical task force and also at the incident management team. So that is in place, but it's not like available to the entire public. But yeah, we have the dashboards in place. Yeah.
Okay, so this is more used as an internal tool for the committee.
Exactly.
Yeah, and then perhaps the very last one on testing. What is the average turnaround time to get test results, and how are both positive and negative test results being communicated to people who have been tested? So this is a question of Mariam Hassan.
Okay. So the initial turnaround time was pretty high. It was about a week when we started testing. And this was also just because of the backlog of cases that needed to be testing. But right now the turnaround time has come down to about 1 day. So most people are able to get their results within a day. And in terms of how the results are being communicated, we have the healthcare worker, but we also have counselors who are actually involved in giving the results to people. There's a lot of stigma associated with the testing positive. So there's a lot of counseling that we've really had to put into place in order to mitigate the mental health effects as well.
Okay. Let's move on perhaps to the next question. You mentioned the number of measures that have been taken, and so there's some questions on the adherence of these measures, but also the enforcement of measures. One being about the enforcement of movement restrictions. This is a question of Roderick. And the role of the police force in these, let's say, the enforcement with potential or real incidents of police violence in imposing curfews, and also the issue of corruption, bribery, and how measures can be circumvented that way.
Yeah, I think those are very important questions. In terms of enforcement, the police has been involved in enforcement, especially of the curfews the 7 p.m. to 5 a.m. curfew, but also in manning the different borders and making sure that, cities are actually on lockdown. So we have actually, unfortunately, seen a number of cases of police brutality. I think about 5 people have actually died because of police brutality during this COVID period, where the police have actually beaten up people that they found after 7 p.m. Some of these cases have actually been of motorbike riders who are taking people to hospital at night. The other unfortunate thing that we've also seen, for example, is people delaying to seek healthcare. Like women, for example, who are supposed to deliver at night, concerned about seeking healthcare because they are concerned about police brutality. And we've actually also had a number of cases of maternal mortality because of this. So this is very, very unfortunate. And we've seen that. And after this, there's been a lot of communication to the government and with the police as well about police brutality. In terms of adhering to the public health measures, there's a survey that we are carrying out as a country with one of the organizations every 2 weeks, looking at adherence to some of these measures. And by and large, people are actually adhering to some of the measures such as hand washing. I remember the survey, for example, said that 77% of the people, including those who are in slums, had washed their hands at least 7 times the day before. So, so largely people are adhering, for example, to hand washing and sanitizing and wearing masks because it's actually an offense. If you're found outside without a mask, you'll be put in jail. So people are adhering to those measures. But in terms of masking, it's not very clear that people are adhering to wearing masks because, they're trying to prevent themselves from COVID or because, they don't want to get into trouble with the police. Mm-hmm. Now, in terms of the borders, we've certainly had issues of people, they're sort of like unmanned or porous borders. We've had cases of people going through those borders. We also had a situation where people faked a funeral and so said they were traveling for a funeral. And those people actually then took COVID. Those are the first instances of COVID that we actually saw in the western part of Kenya. So those situations have been there. But the government has also put in place a system to make sure that those people who have to move, such as healthcare workers, for example, have passes through certain institutions. So you can get a pass as a healthcare worker from the government or from the Kenya Healthcare Federation if you're a healthcare worker in the private sector. If you're in the agriculture industry, you also get a pass to be able to, to cross borders to distribute foods. So there are measures to mitigate that, but certainly there have also been challenges with adherence. Yeah.
Okay, thank you. Then there's a question of Stephanie Top. This is about risk communication. How was the risk communication carried out? And was it effective? Do you think it was effective, including to the more remote and rural areas to which the infection seems to spread now?
Yeah. So actually one of the things that struck me very quickly was the embracing the measures, the mitigation measures by the public very quickly once they were put into place. And I think to a large extent that the communication that was put in place actually played a part. So this was by government, but also by various NGOs, including the NGO that I work for, Population Services Kenya. So the communication that has been put into place is both mass media. So we have messaging on TV, we have messaging on radio as well, but also we also have interpersonal communication by community health workers that go door to door and are at community level. So I think to a large extent that has been effective. But what we have started seeing, especially of the past 2 to 3 weeks, is sort of fatigue. And also with the low cases that we are seeing, largely because of all the mitigation measures, then people think that then we don't really have a problem. If we only have 71 deaths, the community is also thinking that it's not so much of a problem, although that is probably because of the mitigation measures. So there's a bit of fatigue creeping in.
Yep. All right. Let's move on perhaps then to the system aspects, the system preparedness, the response, and the first question about the decision-making processes. There's a question about the WHO and the role of WHO in Kenya in the response and development response.
Yeah. So the WHO is also a part of the task force in Kenya, the technical COVID task force, and we've been working very close with them. So I think a lot of the what the WHO has been useful in doing is especially bringing recommendations and learnings and also in development of various guidelines. So supporting the country in development of various guidelines, such as the case management guidelines. As well, we had the interim guidelines. We are actually updating the case management guidelines. But one of the contentious issues, for example, was, should we use hydroxychloroquine for management of patients? But we've had a lot of support from WHO to really base our guidelines based on available evidence right now. So we are not recommending the use, for example, of hydroxychloroquine for management of COVID cases, just because we don't have the evidence to support that.
Yeah, all right. Then you kind of showed how the national committees were quickly set up to deal with the epidemic quite early in the process. There's a question from one of our colleagues, Bert Kriel, on the evolution of your health system and the role of the counties. And even at lower level, the districts, of course, and then perhaps even lower at the municipal level. So are they being involved in the COVID measures, and how?
Yeah, that's really important, because the counties actually have the mandate of healthcare in their own county. So it's absolutely important to involve them. So at the National Response Center, the ministerial structure that I was talking about, we have a representative, the chair of the Council of Governors, sits on that committee as well. But we also have various counties that are actually, the county ministers of health are also part of the COVID technical task force team. And the surveillance is also county-based. So there's a lot of engagement between the national and the county government. The role of the national government being very clear is to really set the direction, the response, come up with the guidelines and protocols, but the implementation is actually at county level. So like, for example, the counties are actually the ones who actually identify isolation and quarantine centers at county level. That is actually done by the counties. Contact tracing is also being done at county level. So there's a lot of coordination between the two.
Okay. Okay, that's more a question from my side. Do you think the system will become stronger because of this now, let's say, forceful and enforced reaction to the pandemic?
I'm very hopeful about that. I think there's been a lot of visibility of the health system, and also a lot of awareness of the inadequacies of our health system right now. So the government, for example, very quickly, recruited 3,000 healthcare workers to be deployed. And that was because they actually assessed, and so, we actually have an inadequate health workforce. Some of the other things that, have really been brought to the spotlight is, the ICU capacity that we've had. We have known for years that our ICU capacity is inadequate and has really been localized at very few sort of major hospitals. So that has been put on the spotlight. We've had data on, so many counties actually don't even have any ICU beds. So that has been put on the spotlight. So I'm very hopeful right now that the measures, even the diagnostic and the lab capacity that we're strengthening right now, will be useful for the health system moving forward.
Okay. There's a question of Gabriela Ribera about a plan to address the anticipated issues caused by lack of primary healthcare during the COVID crisis. So it's a question about, let's say, the collateral damage. You already mentioned antenatal care, maternal services being hampered. What is the strategy to do something about this?
Yeah, so I would say the strategy is twofold. So one is that in all of the different counties, they have actually established separate COVID isolation centers. And the communication out to the public is that it is safe to come to the healthcare facilities. You will not interact with the COVID patients. And so this is part of actually of the communication that is going out to the public right now. People have been very scared of going to hospital thinking that they'll get COVID from there. But the other thing is really also strengthening the availability of services through the community health volunteers at community level, both preventive services. So for example, like family planning services, for example, this has really been scaled up through the community health volunteers. So some services that can be provided at community level are being provided, but also people are being encouraged to come to the health facilities because we have separate COVID centers. Yeah.
All right. I think this is also already a response to the question of Richard Omore about the lack of trust and the non-use of service. So we'll skip to another question, a question more about how people, communities look at the infection and at the pandemic. It's a question of Theo Katsuva. What does the community in general think about COVID-19? Is it considered to be a disease of rich people, a man-made disaster, fiction? This is also pointing to the issue of false truths and the media.
Yes. So there were a lot of misconceptions, especially at the beginning. Most of the cases, like one of the very first cases in the country was actually of a pilot who unfortunately eventually died, who was transporting people from the US to Kenya. And so there's a lot of visibility around that case. And so the community was saying, this is only amongst people who've been out of the country. So most people did not think they were at risk if they hadn't been out of the country. But now with the increasing of the cases, especially in the informal settlements, there's really a realization that, COVID is really spreading everywhere, and everyone really is at risk. It's not only people who have been out of the country. Mm-hmm. But there have also been some, because, many people still don't know anyone with COVID. There's still a bit of skepticism amongst the people, whether is this really true? Is this a global conspiracy? Is the government, faking numbers in order to be able to get international support? So all these discussions are there at community level, but I would say that by and large, Kenya is really, I would say the Kenyan people are really aware that COVID is there, because even when you go to the rural areas, I was talking to my mother, for example, in the other weekend, she's really in the rural areas, and she tells me that, everyone is wearing a mask, and this is a really remote part of Kenya. People are still wearing masks there, they're hand washing, they're keeping social distance. So I think by and large, the realization that COVID is here with us is there. Yeah.
All right. Then perhaps a question or a number of questions on the effects of the measures on actually the informal sector, people working in fact in non-formal employment. Will there be any economic cushioning for individuals in the informal sector? Is it possible to do so? That's an anonymous attendee question.
Yeah. Yes. So yes, the government actually, I'd mentioned earlier that the government actually established an economic stimulus package. Most of it is actually targeted to vulnerable populations, especially those in the informal sector. It's to the tune of 40 billion shillings, which I think is about $400 million. And so they're supposed to be cash transfers of about $10 per week to vulnerable families and to the elderly as well. So this is it's just being rolled out right now. So we are yet to see the impact of that. Yeah. Yeah. And it's obviously not adequate, but it's something.
Yeah. Okay. Related question, but then back to the formal sector, is a question of Gareth White of our department. Which part of the Kenyan economy has been the most affected by the COVID pandemic? And do you see any kind of short-term or longer-term impacts that will differ across sectors? Will there be preferential treatment for some sectors or higher impacts of particular sectors of the economy?
Yeah. So obviously, certainly the entire economy has been affected, but those most affected are the tourism and the flight industry. So our national carrier, Kenya Airways, is actually seeking a loan from the government right now just to stay afloat. The tourism industry, this is usually the busiest period between sort of May, June, July, and August. It's very seasonal, so they're really down. And this affects largely parts of the coastal part of Kenya, so Mombasa, Kilifi counties, and so on. But also the other sectors that are really affected are the hotel industry. Even with even when the economy starts picking up, we are likely going to have less physical meetings that used to happen in hotels. We'll have many more virtual meetings. So I actually see the impacts of this. They'll be here with us for years in these industries, especially in the service industry. Yeah.
Which of course is going to be important given the quite important contribution of this sector to the gross national product in Kenya.
Absolutely, yeah.
It's a kind of question, follow-up question to that. To what extent or let's say, how could you explain the difference at this stage between your neighboring countries and Kenya, in the sense that the number seems to be higher, relatively higher. It's not dramatically higher, of course. I mean, the absolute numbers are still quite low in your region of the world. Is this due somehow to the kind of the hub that Kenya is? Definitely Mombasa, Nairobi, trade-wise, communication-wise. Is that part of the explanation, you think?
That is certainly part of the explanation. Kenya is really a regional hub, an East African hub. there's much more, travel between Kenya and other parts of the world than you would, for example, with many of our neighboring countries. But compared to Uganda, for example, Uganda, I think, has over 400 cases now, but no mortality. I can't explain the mortality. We actually are having, we'll be having a discussion with some of our ITM colleagues tomorrow. And we are very curious to hear what measures Uganda has put into place. But I also think Uganda also has a very strong sort of history of dealing with, Ebola, yellow fever, that Kenya doesn't have as much compared to Uganda, for example. Regarding Tanzania, we really don't have a lot of data right now on what is happening in Tanzania. So it's very hard to say whether the cases on the rise, on the decline, have stagnated. I really can't say what is happening in Tanzania.
Yeah, all right. Now I'm looking at the watch. I see it's almost, well, in fact, we're over time already. I will suggest to just have one or two more questions, and then we will wrap up this session here. And this is about the exit strategy. So you need to think about, okay, we don't know yet whether you've reached your peak or not, perhaps, but let's think about the exit strategies. The question of Nesfin, Mikon, and Moliso. What measures do you think the Kenyan government will take if this nightmare doesn't end, and if it will take more than 5 to 6 months, and especially for people who can't work from home, who actually need to go out to survive? Yeah.
So you're absolutely right. I think increasingly we are realizing that this is a marathon, not a race. We are going to be, this is really going to stretch out for a while. The projections are right now that the peak will be sometimes in February next year. That's the current modeling that we have, from the university and our Ministry of Health. And so what the government is doing, obviously, is really ramping up capacity in the healthcare system to be able to deal with these cases when they come. But in terms of the economy, so one of the things that the government has put into place that I talked about is an 8-point stimulus package. So this stimulus package is not only a cash transfer to vulnerable people, but it's also really injecting cash in various sectors of the economy. So like, I talked about manufacturing, but also the youth are also being engaged to, I think about 200,000 youths are being targeted to be employed on short-term contracts to build roads, to deal with the hygiene during this COVID period. So really just to pump in funds into the economy. But I think largely everyone will really have to take, all industries really, things are going to be different. Whether it's from the telecommunication industry, we don't know whether the reduction in tariffs is going to continue in future. It's really hard to tell, but there are a lot of discussions right now, and things are unfolding very rapidly every week.
Yeah, I think that's a nice comment to end. We've run out of time. Unfortunately, there are a number of questions remaining, but as you know, you can pursue the discussion on the discussion forum of the alumni website. What I would like to say at this stage is this has been a quite interesting presentation. It gives us lots of insights in what's happening in Kenya. I would just encourage all of you, the alumni, as much as we, of course, to be engaged in research on this, and especially to figure out what's really happening in terms of the decision-making processes. It's too early at this stage, you're in the middle of it yet, but I would encourage lots of you and all of you, if not, to really try to figure out, okay, how do we respond to this crisis and how do we manage to control it, if you want, to mitigate the effects, but to such an extent that the most vulnerable are not going to suffer the most, of course. So thank you very much, Anne. Just to mention also that this presentation will be available on Facebook, if I'm not wrong, and also downloadable at some point. So definitely people who would like to see the presentation, they can get it. Thank you very much.
Thank you very much.